Hi everybody, and welcome to our module on Staphylococci. So this is our algorithm for gram-positive bacteria, and recall that there are the gram-positive cocci, and there are two groups of gram-positive cocci. There are the streptococci, which we'll talk about in another module, and then there are the staphylococcus, which we'll talk about in this module. The most important staph is Staph aureus. It causes a lot of disease, and then there are two less important staph, which we'll also talk about, Staph epidermidis and Staph saprophyticus. So in this slide, I've summarized the names of the three staph groups that you need to know, and as I said before, they're all gram-positive cocci. Also recall that they all form clusters, and also recall that they are all catalase positive. That's what makes them staph and differentiates them from strep. So we're going to start by talking about the most important staph, which is Staph aureus, and it has a couple of special features you need to be aware of. First of all, you should know that its basic habitat is the nares, or the nose. About 30% of people carry Staph aureus. We don't really understand why these bacteria can live benignly in the nose for so long and then sometimes cause infections. Staph aureus produces a yellow pigment, and you need to know that. And the easy way to remember it is that the word aureus actually means golden, and it's named for that reason because it makes this yellow golden pigment. Staph aureus is beta hemolytic. Now normally we talk about hemolysis patterns for strep because we differentiate strep bacteria by whether they're alpha, beta, or gamma hemolytic, but you need to know that Staph aureus is also beta hemolytic because this often comes up on exams. Staph aureus is coagulase positive. This is what differentiates it from the other types of staph, and this means it has the coagulase enzyme present on its surface, and it can form fibrin clots when you place it in plasma. An important virulence factor is protein A, and I talk about this in the module on virulence. This blocks the Fc-IgG interaction, and it prevents phagocytosis and complement activation. And you can just remember the A in Staph aureus stands for protein A. And in addition to causing disease by infection with bacteria, Staph aureus also causes several toxin-related disease, and we'll talk about that in a minute. Staph aureus can cause a lot of different infections and illnesses, and I've summarized them on this slide based on whether they're caused by a toxin from the bacteria or by infection by the bacteria itself. So the three toxin-related diseases you should know are the toxic shock syndrome, which is caused by Staph aureus secretion of toxic shock syndrome toxin 1. Staph aureus can also cause food poisoning by release of Staph aureus enterotoxin. And finally, it can cause scalded skin syndrome by release of a toxin called exfoliatin. The infectious diseases it can cause include a lot of skin infections. So remember, it's present in your nose, but it often gets on the skin because a lot of people pick their nose or touch their nose. And when it gets on the skin, it can cause impetigo and cellulitis. It's a rare cause of pneumonia. It can also cause endocarditis. It can cause osteomyelitis, and it can cause abscesses, especially in the tonsils and on the skin. So we'll talk about all these illnesses in the next few slides. So first let's talk about the toxic shock syndrome. So this occurs when Staph aureus secretes toxic shock syndrome toxin, or TSST1, and it gets into the systemic circulation. The classic scenario for this is someone who is exposed to staph and also some type of packing material. So women who are using tampons or surgical wounds that have been packed, if those wounds get dirty, the staph can thrive and it can release this toxin into the systemic circulation. The symptoms of toxic shock syndrome are fever and shock, as the name implies, which is hypotension, and a diffuse red rash. It's called erythroderma, and it looks like a sunburn. After a few weeks, actually, the skin will desquamate, especially on the palm and soles. And diarrhea is very common. So one thing I always recommend you remember about toxic shock syndrome is that in general, it's just going to look like someone who is infected with shock. They'll have a fever and they'll be in shock. But the things that'll tip you off that it's a toxic shock picture are this red rash, which is very unusual for sepsis, and the diarrhea, which is also very unusual. And then finally, especially in board questions, they will usually give you some type of clue about a woman using a tampon or a surgical wound that's been packed for several days. Staph food poisoning happens when a food handler contaminates food. So it's kind of gross, but a food handler picks his or her nose or touches his nose and then touches the food. And it often happens when food is left at room temperature for several hours. Staph can thrive in this environment. In fact, a picnic is a classic scenario. So what happens is the bacteria gets from the food handler's nose into the food, and then the bacteria grows and produces enterotoxin. And you ingest the preformed toxin to get sick. And this is an important point to remember for board questions. They like to ask you about this. It's not that you ingest the bacteria and then it produces the toxin in your belly. What happens is you ingest the toxin that's already been made in the food at the picnic. And because you ingest a preformed toxin, the GI illness develops relatively quickly, usually 3 to 6 hours later, and this differentiates it from some other causes of food poisoning. People usually get nausea and vomiting and abdominal cramps, and what you want to look for are multiple sick people after eating at a picnic. The classic food is mayonnaise. Staph thrives in mayonnaise, so watch out for people who ate potato or egg salad at a picnic and then start vomiting 3 to 6 hours later. Scalded skin syndrome is a condition that occurs in newborn babies, and it's caused by Staph aureus exfoliative toxin, which is also called exfoliatin. It classically occurs about 3 to 7 days after birth. These babies will get fever and a diffuse red rash starting at the mouth. As time goes on, the skin will slough off. Now, one thing that's important to know is that the toxin destroys keratinocyte attachments in the stratum granulosum only. We'll see a picture of this in a minute. But this is in the middle of the epidermis, so the damage is intraepidermal, and this means that the dermis layer is intact, so the skin can heal completely with no scars. And one of the findings in babies who have the scalded skin syndrome is called Nikolsky's sign. This is when the skin slips off with a gentle tug. And here's a picture to remind you of the layers of the skin. So all these layers up here are the epidermis, and the dermis is down here at the bottom. So the stratum granulosum is right here in the middle, and this is the layer that's going to be affected by the Staph aureus toxin. And therefore, the epidermis layer up here can slough off, but the dermis can regenerate and the skin can come back without any scarring. Staph aureus can cause a version of the skin infection impetigo called bullous impetigo. So impetigo means a skin infection, and it's generally caused by group A strep, although it can be caused by staph. But for your boards, you should think of impetigo as a group A strep infection. And this is a picture of someone with the regular form of impetigo here, and the lesions are always described as honey-colored and crusted. Bullous impetigo is a variant of impetigo in which people get bullae, so recall that bullae are fluid-filled sacs, and they're similar to a blister, which you've probably had. And the bullous version of impetigo is caused by Staph aureus. It classically occurs in children. All forms of impetigo classically occur in children. And impetigo is easily spread from one child to another, so what often happens on pediatric rotations is you see children that were sent home from school because of a skin infection, and they aren't going to be allowed to go back to school until the pediatrician says that the infection is not impetigo or that it's cleared. And one thing to know about the bullous impetigo form is that it's caused by Staph aureus strains that can make the exfoliative toxin. So it's an infection with the bacteria, but then the exfoliative toxin also contributes, and it's what turns it into this bullous form instead of the typical form like you see in the picture right here. Staph aureus is a rare cause of lobar pneumonia. I talk about this in a little more detail in the pneumonia module in the pulmonary section. It classically occurs as a post-infectious pneumonia. So somebody will get the influenza virus and then recover from the influenza virus, but then their recovery will be interrupted by another infection caused by bacteria, and that's classically a Staph aureus lobar pneumonia. Staph aureus is a classic cause of acute endocarditis. So by acute, I mean that there are a rapid onset of symptoms with a very ill patient. And Staph aureus is a virulent bug, so when it gets into the bloodstream, it often can cause disease in patients who have normal hearts, so they don't have any pre-existing valve disease like mitral valve prolapse. Contrast the acute form of endocarditis caused by staph with the subacute form, which is caused by strep viridans. So strep viridans is a mouth flora. Endocarditis from strep viridans has a slower onset of symptoms than acute endocarditis. The patients are usually less ill. And strep viridans, because it's less virulent, often requires a prior valve abnormality in order to be able to attach to the heart. So these patients will often have a history of mitral valve prolapse or some other valvular condition that predisposes them to endocarditis with strep viridans. One way that patients often get bacteremic from staph is from insertion of central lines. So we put a lot of central lines in patients, especially sick hospitalized patients in the ICU. And if you do so without washing your hands and putting on sterile gloves, you can introduce staph, which are present on your hands and your skin and in your nose, into the bloodstream of the patient. The most important way to prevent this is to use good sterile technique. So if you're ever asked on a board question, how could staph bacteremia have been presented? The answer is to wash your hands before you put the central line in, and then also use gloves and also use sterile insertion practices. Some of you may know that checklists are often used in intensive care units to make sure that everyone has properly washed their hands and prepped the patient, and these checklists alone have been shown to reduce rates of bacteremia because patients then put the central line in under sterile conditions and they don't accidentally make the patient sick. Osteomyelitis is a rare infection, but when it does occur, Staph aureus is a common cause. In children, they usually get osteomyelitis in their long bones, like the femur, the tibia, and the fibula. In adults, the bacteria usually land in the spine and cause infection there. There are a couple ways by which the bacteria get to the bones to cause osteomyelitis. The bacteria can spread through the bloodstream. I just described for you how you can accidentally introduce bacteria into the bloodstream with a central line, and if that happens, not only can endocarditis occur, but also osteomyelitis. Patients who have damage to the skin can get spread from the skin and soft tissues into the bone. So one way this happens in the hospital a lot is patients who sit in bed all day get bed sores and the tissue breaks down, and then the staph can get directly into the bone. And then if you have trauma or you have surgery, sometimes this can introduce bacteria into the bones. The symptoms are usually localized pain plus or minus fever, but really the diagnosis is usually made by imaging. So if someone's got a wound or if someone's got a lot of pain, imaging will be done, and you can see on chest x-rays or CT scans or MRIs some evidence of osteomyelitis. This is a good point to just pause here and review the classic causes of osteomyelitis that you should know for your board. So in a child, it's often from Staph aureus from some type of hematogenous spread. Sickle cell patients classically get osteomyelitis from salmonella. Sickle cell patients are functionally asplenic, meaning that their spleen does not work properly from all the sickled cells, and salmonella can thrive in patients who don't have a functioning spleen. Patients who have tuberculosis in the lungs and then get pain in their back often have what's called Pott's disease, and this is where the tuberculosis mycobacteria has spread to the vertebra or spine. Diabetic patients often get polymicrobial infection from foot ulcers, so they have neuropathy and they can't sense their foot, and therefore they get an injury to their foot and they get a foot ulcer, and this introduces bacteria into the soft tissues and it can spread to the bones. So one of the most feared complications of diabetes is to get osteomyelitis in the foot and potentially go on to require amputation. And then, as I mentioned in the last slide, patients who are bedbound often get pressure sores. It's usually on their back or on their rear end, and they get breakdown in the skin, and then bacteria can get introduced into the soft tissue and ultimately into the bones. Staph aureus can cause cellulitis, which is a relatively common skin infection. This is a picture of somebody with cellulitis of the leg right here. It often happens after patients get an injury, like a cut, and then bacteria get into the dermis and subcutaneous fat. And the cellulitis is mostly caused by beta-hemolytic streptococci. However, Staph aureus is a possible cause, and the reason this is important is that when you select antibiotics to treat cellulitis, you often select antibiotics that cover staph. You don't want to choose antibiotics that only cover strep because the patient may have a staph infection and then it can get much worse. Staph aureus can cause certain types of abscesses. So abscesses are infections that are walled off in deep tissues. They're filled with bacteria and inflammatory cells, which most people just call pus. And skin abscesses, you should know, are commonly caused by staph. And this should make sense to you because we've talked about how staph is present in the nose and often gets on the skin to cause infection. Skin abscesses go by a couple of names you should know. A furuncle is a boil. It's an infection of a hair follicle. A carbuncle are multiple boils clustered together. Staph can also cause tonsillar abscesses, so remember that it lives in the nose and it can sometimes get into the mouth and it can cause abscesses in the tonsils. And the mainstay of treatment for any abscess is incision and drainage. Antibiotics often can't get inside enough to control the infection, and usually it requires a medical procedure to get rid of all that pus. So let's review the Staph aureus antibiotics. So you need to know that most strains of staph are resistant to penicillin, and this is because staph often produces beta-lactamases, which are enzymes that inactivate penicillin. So options to cover Staph aureus include anti-staphylococcal penicillin. So these are beta-lactam drugs that have been modified so that they can work in Staph aureus. And these include drugs like dicloxacillin and nafacillin and oxacillin. You also can choose first-generation cephalosporins. These work very well, especially the drug cephalexin. And in fact, cephalexin is often given to patients with staph skin infections to treat the bacteria. And then finally, you can administer certain beta-lactam antibiotics plus an inhibitor of beta-lactamases. So for example, amoxicillin is a beta-lactam antibiotic, and you add the beta-lactamase inhibitor clavulanate, and then the drug will work to cover Staph aureus. There are strains of Staph aureus that are called methicillin-resistant Staph aureus or MRSA, and these are very dangerous infections. These versions of the bacteria are resistant to all beta-lactam antibiotics, and the reason is because they express altered penicillin binding proteins. They're usually a hospital-acquired infection, although sometimes they can be a community-acquired. And if you have a patient who you think has MRSA or you know has MRSA, the antibiotic most people go to is called vancomycin. but you can also use daptomycin. These two are the antibiotics of choice. And you can also use a drug called linezolid. And I discussed the mechanisms of all these antibiotics in another module. Now let's talk about the other two types of staph besides Staph aureus, and we'll start with Staph epidermidis. So Staph epidermidis is a normal skin flora. It's found on everyone's skin, and it normally doesn't cause any type of illness except in two clinical situations. The first situation is that it's often a contaminant of blood cultures. So when you draw a blood culture to look for bacteremia, you have to stick a needle into the vein and withdraw some blood and send it to the lab. In sticking that needle into the vein, you will often contaminate the blood culture with Staph epi if you haven't used good sterile technique. So what often is done is usually 4 bottles of blood culture are sent to the lab. You put some blood into 4 different bottles, and you'll get, for example, 1 out of 4 bottles showing growth of Staph epi, and that's usually a contaminant. True bacteremia will often result in growth in all 4 of the bottles. The second clinical situation where Staph epi is important is that it can infect prosthetic materials in blood. So there are surface molecules on the bacteria that aid in adherence, and it likes to attach and then produce biofilms. So for example, if you have a catheter in the bloodstream, for example, for introducing chemotherapy to a patient, it can get contaminated with Staph epi. Pacemakers can get contaminated. Prosthetic heart valves are a classic place for infection with Staph epidermidis to occur, and also prosthetic joints. Staph epidermidis is almost always methicillin resistant, so you have to treat it as if you are treating methicillin resistant Staph aureus, and the treatment of choice is to use the drug vancomycin. And the last staph that we'll talk about is Staph saprophyticus. This bacteria is a common cause of UTIs, especially among sexually active young women. It's high yield to remember this demographic. Most UTIs are caused by E. coli, about 90%, but there are some other bugs which can cause UTIs. These include Proteus, Klebsiella, and Staph saprophyticus, as well as, in rare cases, Enterococcus. Some key features that should tip you off in a board question that they may be describing a case of Staph saprophyticus infection are, first of all, sexual activity. This infection of the bladder commonly occurs among women who are sexually active. In fact, infection with this bacterium is sometimes referred to as honeymooners' cystitis because women who are on a honeymoon and engage in lots of sexual activity often develop a Staph saprophyticus UTI. Another special feature of this bacteria is that it is nitrite negative, so when you do a urine dipstick, there will not be nitrites detected in the urine, and this is different from many other bacteria that cause UTI, especially E. coli. E. coli is nitrite positive, so if they describe a case of a urinary tract infection in a sexually active woman and tell you that the nitrite is negative, this is one of the main bacteria you should think of. And Staph saprophyticus is treated with the usual urinary tract infection antibiotics, so it can be covered by fluoroquinolones, by Bactrim, and also by nitrofurantoin. These are the 3 major antibiotics that are often used to treat UTIs. And that concludes our video on Staphylococcus.